We're going to do some Q&A. I'm going to have staff, probably Dan and Ruth, who will be posing the questions to you as they come. And what staff does is try to cluster them if similar questions together. So Dan, I'll turn it over to you.
Sounds good. Thank you, Dr. Bardach. Thanks, Superintendent Monroe. All right, Ruth, nice work. Thanks for organizing these questions with the clear set of questions for Dr. Bardach. Much easier here. All right, so Dr. Bardach, I know you touched on it in the slides. I think this question was asked maybe before you got to it, but I'll ask it anyways in case there's anything to expound on. How are middle school student transmission unique compared to elementary and high school?
Mm-hmm. Yeah, it's a great question, and I would love to get more data on it. The best data we have so far is the YMCA data. Most of the data that we've seen, like in the Spanish study, it looked at kids. They chunk all of our data in the less than 10 years old and the 10 to 17 years old. So it's only the YMCA data that gives us 1 year old to 14 years old. And that was reassuring in that in the world where everything was locked down, up to the 14 years old, there didn't seem to be a whole lot of action in those daycares. But I don't have numbers broken down even in that grouping. And then the only pause is the article that I read yesterday from Israel saying that they thought a lot of the transmission happened in the middle schoolers. But like I said, I think that's in the world where they were not doing a whole lot of masking. They weren't doing a whole lot of social distancing. So nobody should be surprised that there was a lot of rampant spread everywhere in every age group, you know, if that's happening. Sorry, I can't answer. Sorry, I don't have an answer for that one.
Thank you. All right, from Cindy, I'm not sure if you're aware of this one. So this is, the question is, what about the school in Montreal in which 9 of 11 students in a class were infected?
Yeah, that's a good one. I tried to find out if that was a high school or not. My impression was that it was a high school, but if you have more information about that, that would be good. It's hard, sometimes it's hard to interpret these data without knowing more about what the circumstances was. Was it a teacher who passed it to them? Was it a kid who passed it to each other? I think in the high schools, we have relatively reasonable understanding that kids can pass it to each other. In other situations, I think it's more often the adult passing it to the kid in the younger groups.
Thank you. Okay, next one's looks like more of a comment, but if you have anything to add to it, feel free. Otherwise, we'll move to the next question. So the comment is, it seems that the distancing needs to be between adults and not so much regarding students in small cohorts.
I think it's an age-dependent thing. I would feel more comfortable saying that the elementary school students, it doesn't seem like it needs to be a lot of physical distancing in the children. I would be much less comfortable with that in the high school students. I think the high school students do need to do physical distancing. I 100% agree about the adults. And I'll say the anecdotes about both from the summer camps in San Francisco and also healthcare workers and even my own research team, the place where we have a failure in adult good social distancing and masking tends to be in the break room. We're not working with patients. We're not working with students. We decide that we're comfortable. We need to have some food. We take off our masks. We sit next to our colleagues and we chat. And that seems to be where, you know, when there's contact tracing for anything that happens in either one of those settings, the healthcare or the school setting, it tends to be that those are the stories that we're hearing. And so, and I had one of my research assistants took off her mask and started to eat. And I was like, you can't do that. We're COVID testing, you can't do that. So that's really, it's not that anybody is bad intention. We're just used to thinking about each other as our colleagues and people we trust. And so we take off our masks. And I say it because it's so normal and it's so helpful for all of us to be thinking as we go back in any way, shape, or form with our staff and student and teacher, blah, blah, to help people remember that is where our mental habits break down.
Thank you. Let's see. There are a few questions around the testing. So I'm going to read all three of them here, and then I'll let you maybe address them as a group. So first one is, can you discuss the sensitivity of saliva tests as compared to NP/Anti-Nares tests? And then the next two are a little more closely aligned. How do we access this anterior test? Do you need any more testing groups for your anterior Nares swabs?
So the saliva testing, it kind of depends on your test. So I would just go, anybody who's thinking about doing saliva testing, there are some good saliva tests out there, and definitely people are using them. It just kind of depends on which one you do. And the lab, you have to, so if you're like, for me, I asked my lab at UCSF, are you thinking about doing saliva? Because it's and sometimes easier to collect. And it kind of actually depends on if your lab has the right equipment to run it. And so that's where capacity is going to be different. But generally speaking, my understanding is the sensitivity is decent and fine for PCR. Oh, and sorry, then the other questions were anterior Nares. Can you just tell me those questions again?
Yeah, how do we access the anterior test? And do you need any more testing groups for your anterior Nares swab?
So the anterior Nares testing, I have been talking, because we're so successful with the kids right now, I've been talking to our lab at UCSF. The anterior Nares does have slight decrease in sensitivity. So the reason we're doing it is based on a New England Journal of Medicine article, which said that the sensitivity, mean how much does it pick up how much is it positive compared to the nasopharyngeal. The nasopharyngeal deep one is considered the gold standard. 94% of the time, the anterior Nares is going to pick it up the same way the nasopharyngeal does, which is not perfect. And so for UCSF to think about doing an anterior Nares swab, they generally are comfortable if they're doing it sort of more broadly for public health surveillance. But if they have a patient coming to the hospital and that patient is about to get a procedure and potentially get everybody else really exposed to an aerosol, they don't want the anterior Nares, they want the deep nasopharyngeal. But they are willing to accept, under certain circumstances, the anterior Nares swab. And I certainly think that for kids, and also for teachers, because we're going to have to do it a lot, and because we want to be able to do a lot of it and get a real sense of what's going on in the community, that the anterior Nares is going to be much more acceptable and doable in the long term. And we don't have right now, as of today, there's no capacity for doing more anterior Nares through me. But I know UCSF is working on actually making it more broadly available, and they're talking to Stanford labs about it as well.
Great. This next one I can appreciate because I think about it every day. Dr. Bardach, if your child's school was diligently following safety protocols, would you send your child to school?
Pretty much, yes. The only caveat would be if there's large community prevalence, and if I was if I felt like there were going to be a lot of teachers who were going to be getting sick there and passing around to each other, I would encourage the school not to open, honestly. I would not be worried about my children's health, and I generally wouldn't be worried about getting it from them, but that's totally, absolutely just a personal thing. And I think one of the important take-home points from this whole discussion over many weeks now for me is that flexibility is important. We're not going to have a one-size-fits-all for every situation, not for every teacher, not for every student, and not for every family. But I would very much send my kids to school right now because I think my kids will do better in an in-person school setting, and I feel comfortable if safety protocols are in place.
Okay. These next few questions I think touch on some Alameda County issues that might be good for Dr. Moss and or Dr. Gerling to join in the conversation with Dr. Bardach. So let's see, can you please speak to the recommendations on the topic of frequency of COVID-19 testing? Weekly, monthly, only if symptomatic or suspected exposure from close contact, with positive case.
There's one interesting dynamic that I think is really important for us to think about, and I would be curious about Dr. Moss's perspective on this, but the DPH guidance and the CDC guidance is for schools and also hospitals and workplaces to do symptom screening. And symptom screening will lead to exclusion of people if they have symptoms. And in kids, COVID symptoms, just in general, COVID symptoms, very vague, cough, runny nose, sore throat, fever. They're kind of overlap with every known viral syndrome known to children, meaning that a lot of kids are going to screen positive for COVID symptoms. And in order for them to come back to school, that means there's generally 3 different options. They can go to the doctors, and if the doctor says you have a very specific other named syndrome, strep throat, something else, then you can go back to school without a COVID test. Or you need to have a negative COVID test, or you need to stay out of school for 10 to 14 days. So in that scenario, I think we're gonna, if we're gonna bother opening schools, we should make sure we have enough testing capacity so that kids don't have to stay out of school for 10 days at a time, which means that we're actually gonna have a lot of testing happening, whether we design a system to drive it or not. So this idea of should we be doing asymptomatic surveillance or not, if we follow those guidelines, we will actually be getting a lot of testing. And so I actually feel like that will set us up to learn, and that will set us up to keep relatively safe. It'll be true testing in kids, testing in teachers. The only other thing to say is that, for our study designs, we would be doing a random sample of asymptomatic people. I don't think that it's essential to be able to do that. And there's some modeling studies that I know somebody at Cal is working on some modeling studies, and they show that monthly testing of teachers doesn't really change our ability to stop transmission, specifically compared to masking and social distancing is much more key. They would be much more effective drivers.
Thank you. I was pausing in case there's any additions there.
This is Louis. I don't know if Nick wants to weigh in, but Naomi, you don't know me. I'm a pediatrician also, but I work for the public health department in Alameda County. And the person who just asked you about the surveillance testing really was asking the question that's most in my mind. And I think we already have systems in place and plans in place to do the symptom screening that you're describing. I also think that it's probably fairly simple for us to set up a mechanism to monitor school absenteeism, which might be a way to, for teachers as well as for teachers and staff as well as for students, which might be a way for us to identify if an outbreak is happening. But the idea of doing asymptomatic testing, testing of asymptomatic people for surveillance, that's new. It's something that we need to really think about. And if there are models out there where that is done successfully and where it assists in early detection of outbreaks, we might want to adopt them. So if you happen to see those kinds of models, I'm hoping you will let us know or build them into your next talks. I think this is the 3rd time I've heard you speak, so you're getting around, so we'll probably hear you again.
I'm sorry.
Oh no, that's great. I mean, we really appreciate it. Nothing to be sorry about.
That's good. Yeah, I have not heard of any good asymptomatic surveillance testing modeling. I think it's probably because our nation doesn't have great testing, like a huge testing capacity. My understanding is that other, particularly Asian countries, I've heard South Korea does it. I think Taiwan might do it. I have not yet actually reached out to those sort of governments and departments of public health. I know George Rutherford has tried a little bit. Anybody who wants to, that would great. It's a great idea. There's one other resource, which is there's a professor at Cal named Zeph Landau, and he was doing some modeling around pooled specimen testing. And so he has some models of how frequently we would have to do it. he has it up to potentially twice a week needs to be done, but that's combined, that is a little bit, because of the pooled testing, actually decreases your sensitivity a little bit, and so you have to do more frequent testing in order to do that. But I do feel like any kind of asymptomatic surveillance, the best way to do is to do random sampling of smaller groups across more schools, rather than trying to do a complete surveillance of every single school and testing everybody.
Right. The real question is, would that reassure us, if we did that, would that reassure us that, you know, the way we're conducting school activities is safe if we don't detect, you know, outbreaks in the asymptomatic population? That's kind of the question in my mind. But thank you for that answer.